the October 15th, 2020 COVID-19 clinical rounds, emergency department. ED staff, mental health support, and fighting fatigue and complacency. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations and agencies who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experiences, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Mondays are EMS, Tuesdays critical care, and Thursday emergency department. Next Monday's EMS rounds will be on EMS airway management during the pandemic. Stay tuned for future topics for future rounds. And as always, we try to adapt these rounds and the topics to meet the demands of our clinical community. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. With that, I'll turn this over to Project ECHO, Amanda Dazan, with Project ECHO for logistics. Thank you.
Thanks. So really quickly, my name is Amanda Dazan. I'm with Project ECHO. Just going to go over some quick logistics. Down at the bottom of your Zoom screen, you'll see a Q&A function. Please use that for any questions or comments you have regarding the presentation or discussion. There's also a chat function on Zoom. Please use that for any questions regarding technical or logistic issues. And we'll also be using the chat for the crowdsourcing question that'll come up in just a minute. Today's session is being recorded and your attendance is consent to be recorded. We appreciate that. The presentation from today is linked to the most recent email announcement that we sent out this morning from Project ECHO, and it'll also be available within a couple days on our website along with the recording of today's session. In about the last 15 minutes, we'll put a link in the chat to claim your CME or CPD credits. That link is also available in the same email that we sent out this morning. And I put something in the chat. If you're not receiving them and would like to, you can sign up. And finally, these sessions are focused on improving patient care and health systems, supporting clinicians. So we appreciate everybody keeping things apolitical. Really quickly, our data use policy is here on the screen. We just want to let you know that we appreciate you submitting all your information during registration, questions, chats, Q&A, answering the polls. We do collect that. However, individual data is kept confidential and we only provide de-identified information. I don't believe we have anybody from NETEC on today. But really quickly, NETEC does have a webinar series that complements these Project ECHO clinical rounds, and you can go to the NETEC website to participate in their upcoming sessions. Also, a quick reminder that AAMC has the clinical guidance repository, and that is available on the website on there. We can also put that in the chat for you. It's continually updated. And now back to Dr. Hunt for the crowdsourcing question.
Thanks very much. In the title for these rounds, I used the word complacency, and actually that's the word that has been used by many during our now, I think this might be our 79th rounds, but it's been used by many in the chat, in the QA, and the discussion among participants and speakers and panelists. And it has this feel of like self-identifying as an alcoholic. No, as far as I know, I'm not an alcoholic, but an alcoholic that says, yeah, I'm an alcoholic. Well, I'm complacent, but I haven't yet learned about those strategies that people are finding effective to actually deal with it. So the crowdsourcing today, the question is, what do you think is, or could be, the art of the possibility, or it could be the most effective tool or strategy to fight complacency among clinicians? What do you think is or could be the most effective tool or strategy to fight complacency? I'm really looking forward to seeing these responses. We've all learned from each other through crowdsourcing responses and hope to today as well. With that, it really is an honor to introduce our speaker. I think I've introduced him many times before, but never before as Dr. Brendan Carr, Professor and System Chair, Department of Emergency Medicine, Icahn School of Medicine at Mount Sinai. Joining him today for the presentation will be Dr. Laura Vano. I asked her, like, okay, so give me titles and so forth, and she prefers to be introduced as their departmental well-being champion, which seems to me extraordinarily appropriate for these rounds. With that, I'll turn it over to Drs. Carr and thank you very much.
Rick, thanks so much, and thanks to Project Echo and to all the sponsors for having us here today. It has been a privilege to show up a couple times on the Echo conversations around this, and it's really a great privilege to be here today. Rick is downplaying the secret weapon that I have sitting with me today. So Dr. Vano is really an extraordinary advocate for a very, very thoughtful way of thinking about what well-being looks like and what we can do to support the staff in fighting complacency and in addressing the fatigue that we all know is real. This has been going on for some time now. So I wanted to start things off and sort of set the stage a little bit, just because we are in a different place than we were just a couple months ago. But for this conversation, I think we really do have to take a moment and step back and remember where we were. Laura, if you'd advance that slide, it'd be great. We were at the center of, in New York City, at the center of the beginnings of this. Obviously, there was the West Coast surge, but from the East Coast surge, the first case in New York was diagnosed in the main emergency department of the Mount Sinai Health System on the wee hours. The patient came in February 29th, the result came back on March 1, and they were sent home because they weren't all that sick, which is why, you know, the test came back from the lab in the middle of the night. And from there, we ramped up very, very rapidly. The month of March saw us dramatically rise. The dark blue there are our COVID admissions. The light blue are the patients who were waiting for their lab tests to come back, or PUIs, as we all now refer to them. And then we peaked on April 6th. So just, you know, essentially a month and a couple days after our first diagnosis was that peak. And we, you know, I have said many times, and it resonated with me when the governor said many times that the peak is really a plateau, because it just didn't feel like we were ever going to tip down that other side of the hill. And I'm just trying to put you in a place now where we remember the mental fatigue, the exhaustion, and the absolute terror that we all felt during that time. We admitted during the surge, and you know, obviously things are starting to be a little bit more active now, but the numbers are nothing like they were. We admitted about 11,000 people during that peak area, and we sent everyone home who wasn't sick enough to need to be admitted, and we couldn't test them at the time. You know, we just, I mean, for the first case, right, thinking back again, we did a lot of early testing of all people, and then we were told that we just could not continue to do that because of resource constraints, and so we sent loads and loads of people home and said, just assume that you have it. It's almost certain that you do. And if you get sick enough to come back to get admitted to the hospital, here's what you should be looking for. So it was a dark time, if you want to advance again, Laura. And I'll tell you, you know, as I look back and as I think back and as I talk to people what was happening, I wanted to just paint a little bit of a picture of what was happening outside of our walls. It was one thing to come to work and to be terrified that you were going to get sick and that you were going to bring it home to your family and your kids. I think everybody on the webinar and everybody across the country had to figure out where to house our staff. We had, it turns out, a whole lot of empty hotels in New York City. And so we created partnerships with the hotels. Sinai has a bunch of apartments in real estate, and we put a lot of people in places where they could live. But, we're talking about a 12-hour shift, in a mask, scared, taking care of people, followed by a shower by yourself in a hotel room, a couple hours of sleep, and then waking up and trying to put the battle gear back on to sort of go do it again. And even when you had a break from the hospital, I'll tell you, if you remember, all of our social media feeds, every time we turned on the news, we were reminded that there were morgue trucks, dozens of them parked outside of our hospitals, that there were mass graves being created in Manhattan, that there was not enough PPE, that we were rationing ventilators. Everywhere you turned, it was all consuming, and it was really, really dark. I will tell you that one piece that really resonated with me was the requests that we had of leadership to figure out how to get notaries available for when people came to work, since everybody's offices were closed, so that they could rewrite their wills and so that they could start to assign who was going to take care of their kids should they become critically ill. So that's where things were. And with that as a background, I will tell you, we're fortunate. Our dean is a psychiatrist, and his dissertation, his postdoctoral work, his research portfolio was all entirely around resilience. A lot of time spent talking to Vietnam veterans about what it was like to come back. And when we came to recognize the rates that post-traumatic stress were gonna be generated amongst our staff, people really went to work. And we want to give you a flavor of what happened on the well-being side, but also a real flavor about something that we think is central, which is the bridge. And that bridge from the frontline staff into the resources. That's the piece. That's the piece that we want to hammer on here, because it gets lost. It is very easy, and Dr. Vanyo and I have this conversation, when we're told all of these resources exist, sending an email to the faculty, sending an email to the staff and saying, hey, if you're having a hard time, here's the path forward, just didn't work for us. And so we had to figure out how to communicate, how to strategize, how to be there for each other. So I'm going to give Dr. Vanyo a second here to talk about what wellness is briefly, just because it is not sort of just the lip service that it sometimes is framed as.
Thank you, Dr. Carr. Again, my name is Lara Vanyo, and thank you so much for having me today. So, just taking sort of a step back and thinking about wellness, you can't really talk about well-being without thinking about fatigue and burnout. And we at Mount Sinai have the luxury of having a dedicated Office of Wellbeing and Resilience, which is specifically intended to address the issues of burnout. And in particular, sort of the purple picture right in the middle there, enhancing our sense of meaning in our work. So all of these other sort of dimensions surrounding this really feed into making sure that we feel like what we are doing is meaningful and worthy. And when we do have that sense of meaning in our work, it helps us to feel more engaged, to reinvigorate us, and to really help to combat some of these things we're going to be addressing around fatigue and complacency. When that meaning is lost, and when these other dimensions do not feed into our meaning of work, so when we don't have a sense of social support, organizational support, work-life integration, and things along these lines, then we kind of tip more into that realm of burnout, exhaustion, and cynicism. Consequences of burnout are, of course, pretty enormous, ranging from personal impact in terms of our psyche, from alcohol, substance abuse to depression. In this case, in COVID times, in particular, we worry about things like PTSD, and then the professional side, of course. So increased medical errors, decreased patient satisfaction, costly things for our institutions like physician turnover and reduced hours. So the consequences are certainly real. Back to thinking about the pandemic, from the standpoint of the Office of Wellbeing and our Wellbeing Champion program, what we really found was that there was this pandemic curve of stressors, and we kind of followed that curve in how we responded. So early on in the pandemic, and this is actually quite intuitive, what we really found was that folks were fearing for their basic needs. They wanted to know how to get to work. They wanted to know how they were going to get food on shift with all the restaurants closing down. What were they going to do with their kids out of school? What can I do just to survive, basically? As time went on, this really teetered more into uncertainty. It kind of set in of, this concept of when is this going to end? What's going to happen in the future? Will this current workload continue? Am I going to be furloughed? Am I going to lose my job? What exactly is going to happen? And then sort of on that downward slope of the curve, we enter into processing experiences. The horrific traumas that Dr. Carr pointed to, having morgues outside of our hospitals, taking care of patients without proper information about how to take care of these patients. In a lot of cases at the beginning, these really feed into that sense of grief, loss, PTSD, and trying to figure out how to process something of this enormity. And so from the standpoint, again, of our Office of Wellbeing and our Champion program, it became our goal to address each of these things as they came. We really had to kind of think on our toes and sort of realize in the aftermath, this was essentially what we were doing. But, at the beginning, it really was providing basic needs. And through things like needs assessments, we were able to establish, what folks really wanted. But again, from food to childcare, that's what people really needed. As the uncertainty rose, the recognition that communication would be so key came into place. And so, from our departmental standpoint, we began having town halls with Dr. Carr so that we could make sure there was a clear communication pathway for folks to listen in. We sent out weekly messages and daily wellness tips. And did whatever we could to enhance transparency so that people had a sense of what was going on. This was certainly a challenge and continues to be a challenge, especially with how large our institution is and the many sites and system level communication, but it's something that clearly became critical in making sure that our faculty felt aware and taken care of during such uncertain times. And then, of course, we dive into psychosocial and mental health resources. So this was something that was really interesting in how people responded to what people needed. And I think it was very unique to each department in terms of what worked best. But one thing that came up as sort of an informal plan that has developed into something much larger was something called Battle Buddies, where we would assign faculty a partner who they would simply need to check in on. We encouraged it from the standpoint of check in on your colleague to make sure they're doing okay. So remove that barrier of you feeling like you had to reach out if you weren't doing okay, if that makes sense. And this was something that is sort of trickling throughout the system and that we're making more official. Support groups were something that ended up not being terribly successful for us, but it was something that was set up on a regular basis so that if people needed it, they could join in on virtual support groups to talk about what they need. And I'm happy to talk about that more when we get into the discussion. We have hotlines, telepsychiatry, multiple frontline relief efforts. There's a web app that people can utilize. So lots of different ways to tap into psychosocial and mental health. And then this is just sort of an overview of all the different committees and departments within our resource guide that provides support from, again, our Office of Wellbeing to peer-to-peer support. We have a Center for Stress, so it's lots of different resources that I'm happy to talk about as well. The overall message from Mount Sinai and messaging in general was just so critically important to us in terms of understanding that, our our system understands that we are people and that we're parents, we are colleagues, and that, our health and our lives matter as we go through this process. So I think, overall that really was iterated about Mount Sinai, especially through all the resources that they provided to us.
And I'll just add, Laura, on the piece that some of the frontline faculty, frontline staff didn't see was that we are a huge organization. We're distributed across a big geography, and information flows locally unless there is top-down communication. And so every day there was an email from our chief clinical officer that summarized the key talkers so that you could then socialize it in your settings, right? And that creating that tiered communication structure so that it would come to me as the system lead. I would go to each of the departmental chairs or medical directors. They would bring it to their faculty. And we would do town halls, like Laura said, so that everybody from the department could be on board. But communication 101 is that it has to happen locally from trusted voices. And we didn't get it right all the time, that's for sure. And I'm happy to talk about, the things that we did wrong. But there was a clear plan to try to get this to frontline providers. I'll just throw one challenge out there. One of the biggest challenges that I felt acutely was that many of our staff, our non-faculty staff, don't check their emails when they're not at work. Right, and so it was very easy for the docs that are walking around with their phone that's hooked up to their Sinai email, but decisions about whether or not to sort of send things out via text, to send things to non-official emails. They didn't have any patient information in them. They had updates about the system. I'm a newcomer to New York. I had very little awareness about how rapidly things move immediately into the media space, right? Any email that is sent as some sort of communication internally, you should just assume is going to every media source in town because somebody's girlfriend, boyfriend, friend works for CNN. It happened instantly, near instantly. Your phone would ring after you sent something out. And then we put a lot of our resources out in front of the firewall, so nobody had to get behind the Sinai firewall to have access to them. But it was not the normal way that we do business within healthcare systems. It's usually your official email, right? Because patient information might be coming, and it's usually behind a firewall. So, but we have many more things that we did wrong. If we'd like to hear about them, but I think that we're done. I'm very grateful for the invitation, Rick and Echo, and I'm unbelievably grateful for Laura, who says we're doing this wrong. We have to do it differently. The faculty are worried. The nurses are worried. We need to communicate better. And I'm unbelievably grateful for that.
Brandon and Laura, thank you. I really appreciate, especially like, what I say, yeah, we might have done it wrong, and then like the adaptability, and which Dr. McGreevy, one of your faculty members who was gracious enough to present very early on in our round series in the middle of when you're getting hit really hard. I have just a couple quick questions, and then I'm going to turn it over to the panel. For the panel, because we have a number of you on, if you could do the raise hands thing, and then if you would quickly introduce yourselves as you ask a question or comment, that'd be great. So question. So Brendan, town halls, I'm fascinated to hear about your experience with those, because at least in my experience with doing town halls with faculty and so forth, there's some people that totally shut down. They're not showing up, or you can tell they're not really in the room, even though they're in the room. They really don't want to be there. And actually, Laura, your comments on that. The town halls, everybody showed up, because this is totally different. Pandemic, totally different than any other experience. So how'd that work?
Dr. Carr, do you want to take this one, or do you want me to do? Oh.
Sorry, I'll start. There's different tiers of town halls. I mean, so the health system leadership would do them, the dean would do them, each hospital president would do them, the departments would do them. We were all, nursing leadership would do them. We were all doing them, trying to sort of work off of the same playbook of talking points and information dissemination. And people would titrate according to their level of angst. That is for sure. So never did we ever, for anything, have attendance like we had during the times where the news was saying everybody's out of PPE and you shouldn't go to work. And we were giving tours of the warehouses full of PPE to the union representatives to say it's just not true. So we had to make sure that the accurate information got out there. Our attendance was unbelievable during those times. And frankly, but along with that attendance went some raw feelings and some very hard questions, which I, of course, pointed to Laura to answer.
I would add to that, one of the ways that we tried to sort of lower the barrier to entry so people feel comfortable asking their questions was that they would sort of anonymously send them to me in advance and I would ask them for them. So I think that helped people to feel a little bit more comfortable asking, the things that were really on their minds when we got to these town halls.
Yeah, thank you.
Yeah, that was true for the system-wide and for the hospital-based ones too. There was always a mechanism to launder the questions so that people could ask them.
That's good. Yeah, great. Laura, a specific question for you. So there was in the slide, I think it was a slide before last, where you had the strategies that were used. There was a list. You had the communications, et cetera, et cetera. There are a lot of things on that slide, and it's not like a trick question, but I'm really curious. All those strategies that are up there, so there's like 155 people on these rounds, and they talk a lot in the hallways, their hallways, okay? So out of those, what one would you say probably was the most impactful to help people respond to this?
Really good question. I think I might say some of our communication strategies were the most important. The feedback that we got once we started doing our own departmental town halls was pretty overwhelming, from faculty feeling like they were able to express themselves and ask questions. Yeah. I think a very close second to that would probably be the battle buddies. For those who it did work for, it was a little hit or miss in terms of the partnerships themselves, but for those who did have strong partnerships, I think that was pretty impactful. And then, I guess kind of going from there, the rest. But I would say communication was kind of the big thing that came up over and over again and seemed to be sort of the prime issue that people have been citing and do continue to cite, something that we still are working on.
Rick, I would just add that, but some of the other ones happen quietly. And I will tell you, just to remind us all that one of the medical directors at one of the other health systems in town at New York Presbyterian, Dr. Breen, committed suicide. And that was made very public in the wake of all this. And the degree to which that ricocheted and echoed throughout our health system, throughout the city, throughout the country, we just could never understate, how impactful that was. Overstate how impactful that was. And so I guess I would say, although I agree wholly with Laura that the pieces that we could see were really important, I have to believe that some of the pieces that we can't see, the communication saying, here's the number to call if you're really in a dark place, or the battle buddy referring somebody or encouraging them to seek help, and those one-offs where people got private counseling, and there's little pieces of this, like at cost to who, right? Or under what circumstances, or what about time off from work? Boy, all these little pieces matter so much when you're talking about keeping people healthy and allowing them to get back to their lives. So I agree about the communication, but the deeper pieces that we can't see certainly save lives. There's no question in my mind.
Yeah, help people, and it's help people, but we're talking about like survival, literally survival. Laura, I've been so intrigued with the battle buddy system since Dr. McGreevy said, okay, what was originally working, we're going to try out the battle buddy. And then ASAP, Sandy Schneider talked about how they really worked on not just learning through ASAP, but also promulgating that, et cetera, and many have picked it up. It's been really amazing to watch how that's spread in a most positive fashion. The battle buddy piece did in your system, and I don't know if there's like studies on the best way to approach it, but are individuals self-selecting or selecting their buddy, or is that like externally, like you need to come up with one, or we're going to assign you, or how does that actually work in practice?
So the way that we did it, and I don't have any sort of best practices on this, but the way that we did it was essentially that we would ask folks if they wanted a battle buddy to send us the name of somebody they might be interested in partnering up with. If they didn't, then they were randomly assigned. So we wanted to make sure that everybody had one at the sites that did it within our system, but it wasn't, it was partly left up to them, partly, if not, it was anonymous.
But like everything, Rick, it had to happen locally, right? You know, you ask the medical director to pair up a bunch of the docs, or the nursing director to pair up a bunch of the nurses. And like they, you know, there's an intangible that could never be done from senior leadership. It had to happen boots on ground, you know, for people that you knew could resonate with each other. And it's just worth for a minute saying the ability for someone who's in it with you to understand what's happening and to see the flags that you can't see and have not yet decided that you're able to ask for care for, largely because they're invisible to us, right? And often until it's too late. It's just a different dynamic. It's a different dynamic when it's someone who walks in your shoes, literally, you know, almost literally, right? In the 12 hours that you're not there, they're there, right? And they know what you're going through, and their ability to see when you're afraid, and when you're getting ready to break is critical. And I have to say, the birth of this, at least within our department, was a guy named Al Giwa. Everybody knows Al. He's an emergency physician. He's an ethicist. And he is a reservist and a colonel in the Army. And he said, listen, I get it. All these resources are great, but we need to penetrate the front line. And the front line penetration, if I'm using what the Army taught me, is that we need battle buddies. It was in a faculty meeting. And like, you know, by the end of the day, the medical director had paired people up and we'd reached out to the rest. Kudos.
But that boots on the ground, the culture itself has to embrace it, rather than, I mean, what I'm hearing is culture itself has to embrace it rather than it come from a top down. We're going to change the culture, which is actually my experience in working with faculty too. I mean, it's like, and it worked. I mean, good on you. It's like, you really helped pave the way for a lot of the discussions that have happened in the rounds ever since Dr. McGreevy did talk about, like, we're moving to battle buddy and we'll see how it works. So thank you. Really appreciate the presentations. I'm going to turn it over to our panelists for questions, comments. Okay, I got Dan, then Sandy, then Dave. Oh gosh. All right. But as I do, thank you for the people that have responded to the crowdsource question. There's a lot of stuff in there, a lot of stuff that's already in there. And it's a very interesting, as I've kind of like tried to track and listen at the same time, there's this sort of like the fear part with the complacency, but then what are like the positive things you can do with it too? And I'm not, yeah, that's an interesting dynamic struggle there. Okay, so Dan, you first, then Sandy, then Dave, and then whoever else. Yes. And Dan, a really quick self-introduction, okay?
I'm Dan Gerard. I'm the president-elect of the International EMS Chiefs Association. Doctors, thank you. Your presentation was spot on and perfect. And I really appreciate you sharing your experiences. September 11th, almost 20 years later, we still have providers that are afflicted with mental health issues. And unfortunately, we're still seeing suicides. COVID was most troubling for me because we saw those suicides happen early in the pandemic, very early in the pandemic, while the pandemic was still going on. And we still have no idea of the attempted suicides or the number of people temporarily or permanently incapacitated due to mental health issues as a result of responding to the pandemic. When you think about this, 18 months from now, let's just say that in a perfect world, COVID is gone from the face of the earth. In a perfect world. That's when we're going to probably start to see the beginnings of a tsunami of mental health issues. What are your long-term plans from an institutional perspective to kind of deal with that and provide for those people? Because, you know, think about it, 20, 30, maybe even 40 years, depending on the age of the employee. And again, thank you. You guys really did a rock star.
So Thank you for your question. This was something that really has been thought about quite a bit from the system level, I would say. And one of the sort of key features of our response has been that a group of psychiatrists at Mount Sinai created the Center for Stress and Resilience. And this is something that it is designed to kind of attack this from sort of a longer term perspective, in terms of trying to capture folks who are going to who did experience these traumas, and who could benefit from things like intensive therapy, from resilience training, including individualized resilience training courses, especially as we enter a potential second wave. There are, again, web-based apps and things along these lines that are just kind of easier for folks to access from home, and to with like a slightly lower barrier to entry. And so this that's been sort of one of the biggest features of the Office of Wellbeing's outreach in terms of mental health for the longitudinal, from the longitudinal standpoint. So, it's super challenging, and PTSD is obviously not a very, well understood disease in terms of treatment, and, best practices. We do additionally, actually at Mount Sinai, have an ongoing program through our dean, where they are looking at treatments like ketamine for PTSD. So I wonder if there might be some potential there in the future in terms of actual pharmacological help. But right now, our focus has been predominantly on sort of psychotherapy and psychological treatments that can engage people.
And I would just add that, we did have a little chunk there during the summer where things were really, really, under control. And it emerged then. You're 100%, as you're right? It emerged then. The moment the crisis was done is when it rears its ugly head. And now, we're talking about complacency, we're talking obviously about fatigue. As we're heading into the fall, I feel like we have let our guard down a little bit on how much we're doing to check in, and that we need to ramp that up. And it's a wake-up call for all of us that the leaders got fatigued and a little complacent, and we have not been checking in. The last two faculty meetings, we did not sort of do what we have done for months, which is to leave a bit of time in the beginning to process and to encourage people, if they haven't, to text, call, reach out to their buddy. And I will take it upon myself to make sure that changes.
Thank you, Doctor. Thank you.
Thanks. Sandy, then Dave, and Harry, I saw your hand up, and then we'll do some polls and then do round like we usually do. Sandy.
Yeah, so a couple comments. So ACEP played a role during this pandemic in response of helping those hospitals that didn't have these huge structures like you guys do. I mean, you have in a community hospital of, where there are a half a dozen or a dozen doctors, and they have no resources, they have no psychiatrists, they have no battle buddies. So I think that was our role, and we took it on, and I hope we did at least a reasonable job. But we saw a couple of things that you didn't mention, or you glossed over. One was the importance of the visibility of leadership, where the CEO, where the chief nursing officers, where all of those people were there and present and on scene, things seemed to go better. Okay. And so I think you mentioned something about that, but I think that was absolutely crucial. In a place like Sinai, that might be you, Brendan, as opposed to your dean or your CEO. But for the community hospital, it was definitely the CEO and the medical director of the ED. The second piece, we talk about battle buddies. In addition to the stuff that you talked about, I would add one other suggestion, and that's a group called Theater of War. This is a group that does Greek tragedies. And as I've mentioned on a couple of these webinars, and I'm not sure this one or not, we found out that Greek tragedies are not politically controversial. And so at least as far as we know, there's no group that's either for them or against them. But they do these readings from Greek tragedies that explain really what we're going through, because the Greeks had very similar types of wars and experiences. And then just a comment of something else I didn't hear you mention, and that's the anger. And it may just be because we were, the pinpoint of the United of emergency physicians across the country. But one of the things I had told the staff early on was to anticipate just unmitigated anger rather, just anger about everything, kind of like a teenage girl and their temper, where, everything, the color of the room is wrong, everything is wrong. And boy, did we get it for things that we did and for a lot of things that we didn't. And people, so I think letting people know that are in these positions that anger is going to come, and that it's going to be not directed at those individuals personally, and it's okay to just have somebody be furious at you, because being an emergency physician, we won't remember it 10 minutes later, and we will deal with it. But I thought that was really important, and I would add that to your presentation. I'm open for comments, but do you guys see anger in your?
I think that's dead on, completely true. I mean, I think the combination of people feeling completely, vulnerable and out of control and having all this uncertainty surrounding them was sort of a perfect breeding ground for that kind of anger. And yes, I don't know if you agree with me, Dr. Carr, but I think we definitely.
I think there are words that beyond anger that are what we felt, and I just think that from the other side of it, if you're in the position, if you're on the receiving end of it, the absolute requirement that you see it for what it is and not retaliate is, my God, right? It cannot be overemphasized.
Thanks. Yeah, I want to see that Greek tragedy thing. It'd be nice. And one of the things, Sandy, that you brought up when I heard about that, when you talked about it last week, I think, one of the things that this is once in a century thing, and I think our traditional approaches, reliance on that alone is probably going to be very insufficient now and in the long run. And so, I hate to use the word innovation, but really looking at some out of the box stuff. And what I mean, absolutely from the very beginning, when we had Mount Sinai present really early on, the willingness to adapt and realize when stuff isn't going wrong. Laura, sounds like you're the hero with that one for sure. So yeah, keep doing that. Dave, please.
Yeah, thanks. This dedicated Office of Well-Being just fascinates me. I assume that you had that prior to the pandemic. And I guess a couple questions. What kind of drove that? Was there something that happened that made people want to create that? And in our kind of tight financial situations, are they struggling because of, what's the return on investment, and how are they being measured? And has there been any kind of sense that maybe we just don't have the money to continue to support this?
So great questions. The Office of Wellbeing was indeed established before COVID-19. It was actually established before I came back to Sinai. So it was about 3 years ago, I want to say. And the primary goal was really to kind of try to dig into what's sort of driving our physicians, and to help them sort of maintain and sort of reestablish, I guess, their sense of professional fulfillment in their jobs. And so I think there was, there were there are always financial arguments in terms of physician turnover and things along these lines. And then the other added piece of, wanting to keep our physicians happy. And so that was established, back about 3 years ago, and really came into play during COVID in terms of, trying to mitigate a lot of these horrible things that were happening to our doctors. In terms of the financial side of things, I do My understanding is that the system is very invested in maintaining this program. And it's not just, and just to be clear, it's not just an emergency medicine program. It's completely interdepartmental, spans across the entire system for all physicians. And so I think, if anything, during COVID time, there was recognition that this office was so important in helping our doctors get through it, that I don't see there being any sort of removal of the program. In terms of resources, I can't really speak too much to that, in terms of what the budget will allow the office to do over the next maybe months, but I know that there is absolutely continued support for the program.
Yeah, and we're lucky, as Sandy said, right? And it's a huge health system, a huge school of medicine, and allied health schools. So just the capacity to have, well, at the end of the day, it's a relatively small footprint relative to the size of the institution. Doesn't take a whole lot of content expertise to build portfolios. The pieces that, I worry from an equity side about at some point, the ability to, and Dan, I'm thinking about your comments here about 20 years later, 9/11, right? Still echoing amongst people that don't have a couple $100 an hour to talk to a therapist, right? And so the idea, how, and on the front end in the early days, a health system or a university can absorb that and figure out a way to make it be pro bono, but not in perpetuity. And some of the things that just happened, watching death like this, right, is not something that you shrug off in a couple weeks. And so, what that tail looks like, the Office of Wellbeing will be there, best practices will be there. I'm confident about that. There's a deep commitment to it. But I do think that, at some point it gets referred into private sector mental health resources, and there's a limited tail on those. That's an unfortunate reality.
Thanks, Brandon. Harry, last question, comment before we go to polls. I think there's 8 poll questions, and I know we're getting we're 12 minutes before the hour, but given the importance of this discussion, I think will be really helpful in informing all of us. Thanks. Harry.
Hi, by introduction, my name is Harry Seibold. I'm an emergency and EMS physician from Helena, Montana, and COVID consultant with the Forest Service outside of Yosemite National Park right now in the Creek Fire. I have kind of 2 questions in one about whether you think the emotional and mental energy expended in that first wave, if there's anything left in the tank, and I guess that speaks to resiliency. And my concern is those areas that were hit hard first, I'm wondering if you may have developed more brisk systems of resiliency, and those places that weren't hit as hard are really going to struggle during this second surge. And as the kind of follow-on question is, do you think our strategies for dealing with this secondary surge will need to evolve and be different, or do you think the same strategies we use will be effective this second time around? Thank you.
Boy, Harry, you're in it. So you've been in the classic framework of staff stuff, space systems. On the stuff side, we're in a very different position. It's a different conversation than the one we're having today, but we had a very just-in-time supply chain that was outsourced to a lot of folks, and we brought that entire supply chain. Paul's eyes just lit up. Now we're in his zone. Yeah, that we brought that supply chain back inside so that we had full control over it, and that there's a buffer before we were dependent upon just-in-time supply chains. That's a pivot in a separate conversation. And on the systems, yeah, for sure. We have done a lot to think about what we can do to make sure that we can more rapidly surge and keep our day-to-day operations flowing. On the staff, I think is the focus of today, and it really is, of course, your question. And I share your concern about the amount of gas left in the tank. Some of the things that we're doing are, well, let me also say on the staffing side, it's not just about the tank available to the people that work here. It's about whether or not there are additional staff to bring in to replace and to augment if there's surge. And now that the whole country is so hot, there really are not. There's not premium staff to be had. It was pretty easy, when everything was shut down, to get a whole bunch of, the degree to which the PAs, nurse anesthetists, and nurse practitioners changed the game for us, right? And by the way, our outpatient colleagues or our operative colleagues who just showed up in platoons to do stuff that is outside of their wheelhouse was extraordinary. If we're going to keep the health system running and everybody's getting hot at the same time, there's not premium staffing, and it's going to be a very different thing. Our approach to that has been a lot of trying to, sort of ensure that people are in a healthy place now before they go into it. A lot of communication and transparency, as we suggested before, about exactly what our numbers are, what the modeling for the health system and for the city look like with respect to the numbers. I don't think, none of us believe that we're ever going to see the thousands and thousands of inpatients again, right? And that data is reassuring to the staff to know that if I'm taking care of, half a dozen sick people a day, or if in the hospital we've got 100 instead of 1,000, it is, I think it is helpful a little bit because people can expect it. There's less unknown, and there's lots of narrative, again, a topic that you've covered in ECHO over the last couple of months, but that we're not talking about today, is the progression of the disease and the treatments for the disease. It feels like something we understand now, and that has been helpful. So, I'm of course worried and don't want to ever be complacent, but do believe that we've got a couple different pieces that we are really trying to help people to be armed with awareness around what's likely to happen, around how we can treat it, and what our plan moving forward is. But yes,
Thanks, Brendan.
we lose a lot of sleep over that one, Harry. I'm sure you do too.
Yeah. I want to go to the polls, and Paul, I'm assuming you have the 1 o'clock, so I'll go to you after the polls first if you're able to stay on. If not, understand totally and understand when people need to leave. It really helps when we get like critical mass responding to the polls, as you who participated before have come experts at responding to the polls. So Amanda, Amy, if we can get the polls up. Okay, first poll. And by the way, you see these results, panelists and me, we don't get a chance to respond. And yes, these are shared with HHS, but not individual responses. It helps us all, I think, see where we are with 142 people. And recently we've had around almost 60% responding to each of the polls, which is pretty darn good. People really jump on them. All right, 45%. Give this a few seconds. This one, I had no idea how this was going to play at all. All right, let's stop there. 59% of you voted. Yeah, the most frequent is pretty clear, complacency. Followed by fatigue and mental health. And hey, those 6 of you who responded, none of the above were challenges. Wow, good for you. Let's all go there. Next. Okay, this one is focused on emergency department care providers and leaders, okay? And this is since October 1st. So I'm not talking the whole pandemic, just since October 1st. In general, the mental health of our emergency department staff seems to be all right, let's stop there. 63% of you voted. Thank you. Same 21%, worse 21%, better 6%. We asked this same question on September 10th, and we asked since August 1st, and here were the responses. This is mental health. Better was 6%, Same was 15%. Worst was 14%. And what, not emergency department care provider or leader, 65%. All right, thank you. Next. Do currently available mental health support systems and approaches for clinicians, do they adequately address mental health challenges of the pandemic? And Brandon, this is, the discussion section of the limitations of these polling results is vast. Not randomized controlled trials, selection bias. I mean, goodness gracious.
Yeah, but we know what mental health services are available during blue skies. And it's reflective of the fact that it's a standing challenge.
What's so gratifying is get real-time responses from clinicians in the real world. That's extraordinary. All right, let's stop there. 61% of you voted. 5% said yes, 57% said no, and 38% not sure. All right, next. Okay, this one is sort of same, but replaced with the word fatigue. Okay, this is for emergency department care providers and leaders. And yeah, there's the, I'm not one of those. In general, is fatigue of our emergency department staff seems to be less, same, or more. All right, another 5 seconds or so. We have already 60% have voted. All right, let's stop there. 61% voted. Thank you. 75 of you voted. Thank you very much. You see the results there, and I'm going to read the same question with the responses from the September 10th polling. Same question, except it was since August 1st, okay? So less was 5% compared with 4% now. Same was 10%. Now, what? Same now is 15%. More was 27%. Today it's 31%. And then back then it was 59% were not emergency department care providers or leaders, now 51%. All right, thank you. Next. The biggest impact of fatigue in my organization is, and this is like you only get one response to this. So the biggest impact that you're seeing. Amanda and Amy, don't let everybody see these as they're popping, because I don't want to bias people's responses, but they're bouncing all over the place. Paul, hey, thanks for jumping on. Appreciate it. Like another 5 more seconds. 58% have responded. Let's stop there. Thank you. Pretty diverse in response, but it looks like the highest are not adhering to PPE protocols and staffing. And 4% aren't fatigued. That's great for them. Yeah, wonderful. All right, show it for another couple of seconds. I've seen it as it's been popping, but others haven't seen it. All right, next. There's just a couple others, I think. Which of the following has been most effective for me in fighting fatigue? Again, trying to get the quest for like, okay, what's the answer to this? As people are answering, one of the fascinating things, we did a rounds, and Brendan and Laura, we did a rounds, probably 2 months in, 2.5 months in. We're an intensivist that we had previously presented, went on vacation, and it was like, and they were like really getting, I mean, they were getting hard, went on vacation. And so we had them come back and talk about the vacation, literally talk about his vacation and the challenges with the vacation, like he was used to, couldn't switch off to really have the same kind of experiences in, like, I'm on vacation that was previously. It was a fascinating, okay, so what do we do about vacations now? It's like surely presents new challenges. Let's stop there. There are 63% of you voted. And time with family and friends is the clear winner in terms of numbers of responses, followed by exercise and yoga, 30%. Thanks. Well, show it for another couple of seconds. I'm moving too fast here. All right, let's stop there. And next one. This is again one that I want to focus on, just emergency department care providers and leaders. Since August 1st, in general, complacency of our organization staff seems to be less, saying more, or you're not an emergency department leader or provider. There's one final question related to complacency after this one, then we're done. We'll go quickly around for any last comments, and then we'll close out. All right, let's stop there. Uh, 33% said more, and I'll read you percentages from, again, the response from September 10th. Less for September 10th polling results, less was 5%, same was 15%, more was 20%, and then not an emergency department provider or leader, 60%. All right, last question. I have observed the following consequences of complacency in my organization. This one's a select all that apply, okay? It's only one that we have where you get a chance to like select all of them. Whoa. Yeah. Watching these, there's some fast responses. All right, like 5 more seconds and we'll stop. 53% have voted. All right, Echo, go ahead and let's share the results. I'm gonna let them just speak for themselves. The one about the break room, we've talked about that one in particular, not adhering to PPE protocols of the break room. We've talked about that one on multiple previous rounds. So that one definitely isn't a surprise to me based on what I've listened to. All right, let's stop there and really appreciate everybody's like stepping up and participating in the polls. Yeah. I'm going to go around real briefly to each of you. Harry, Dan, and Sandy, and then I'll get to Laura and Brenda for last word. Harry.
I just wanted to thank the 2 presenters for an incredibly important presentation on this topic, and I'm going to cede my time back to them at the end here.
Thanks, Harry. Dan?
You know, our biggest challenge moving forward is that as long as there's a provider suffering, COVID is still going to be in our community. And so, you know, we just can't let that sunset in people's memories. Great presentation today. You guys are the best. Thank you so much.
Yeah, thanks, Dan. Sandy?
So yeah, first, thanks, guys. It was really great. You guys brought out a lot of things to light. 2 comments. One, I think we need to get rid of the word mental health because what we're going through is not a problem. It's actually normal. It's probably a problem if you're not going through it. And Laura, I thought it was very wise of you to talk about the fact that we all have lives outside of our clinical lives. And it is the little sorrows that just start to add up that just bring this incredible sort of grief, anger, sadness, fatigue. You know, going to the grocery store is not, you know, getting food, getting your food delivered instead of going to the restaurant, not seeing your parents, not being able to hug your children or your parents. Those are just little sorrows that just sort of eat away at our moral and our emotions.
Hey, Sandy, I want to take that one on with you about the language piece on the mental health piece. When I say that, you know, you've been listening to so many of these right along with me, and yeah, on and on. And yeah, we all wanted them to end about 8 months ago. But that being said, the words used by people, by the participants, have been mental health, fatigue, and complacency. I didn't make those up. They came from us. When I say us, clinicians. And that, I mean, I think our language around it not only is imprecise around all disaster stuff, but for this, understanding what is like, how this is normal, and we have to tackle that normalcy in some new ways that are effective. That to me is the challenge. So I'm not sure what to do with that yet, but I think it's a really important point, Sandy. I really do. Yeah. So Laura, and then Brendan, you get the last word. You're the chair. So Laura.
Well, first, I just want to say thank you so much for having me today, and I'm learning so much from folks' comments and from the polls and from everything that people have brought up. I think from my standpoint, we're still very much in this, and it's still very much a work in progress in terms of figuring out, how to best address the issues that are coming forward in terms of our faculty's well-being, and the things that impact us both at work and at home, and how to, exactly as you said, how to address this new normal. What is it really going to look like, and what can we do to help ourselves kind of tackle it? So I think, from our standpoint, we continue to try to think and adapt and come up with the best ways to approach things. We do have the luxury now of having the first wave to give us some perspective on how to move forward. I think we did a lot of thinking on our feet at the time, and now we can kind of take some moments to pause and think about what might work best as we continue on, as this isn't going away anytime soon. So at least there's something there, but it's a time to keep thinking and keep fighting and keep working towards this new normal.
Hey, Laura, really quickly, because I know people have to drop off. It's like 1:13. I get it. But any big surprise in the polling results? Because I mean, you really delved into this. Any big surprises, or pretty much what you expected?
Sadly not. I think it's just, we're at that point where complacency fatigue, it's like it really truly is kicking in, and we see it all around us. So I'm not terribly surprised. And in terms of the question about mental health and whether or not organizations are doing enough, I mean, I almost ask the question, can we do enough? Like, is that even a possibility? This is such a wild time, and this pandemic is so enormous and affecting every single aspect of our lives that I don't even know if it's even a fair question, but it's no, unfortunately, I'm not terribly surprised by the poll results.
Yeah, no, thank you. Yeah. Brandon, please.
I'll keep it quick, and thank you, Rick. I guess I would just sort of end by saying that I have been on on the back end of sort of the worst of it for me. It has really led to an increased awareness about the fact that I don't often enough express my gratitude to the people that are walking into the fire every day. And so I have made a personal commitment to doing that more often, and making sure that I tell people how exceptional they are, how grateful I am for what they're doing. And the authentic connection that I see comes from that, and how that spreads is unbelievably meaningful. I'll end with one little anecdote, which is I did a quick little news thing the other day locally, and within minutes of being done, my cell phone rang. No idea how it happened, but a 98-year-old woman who lives in New York and hasn't left her apartment in 7 months, has been having food delivered and this, that, the other, called and said, you talked about flu shots. I don't know how to get one. I do not want to leave my house. Do you think you could help me? So I don't know what it was. It was 8 o'clock in the morning, 8:30 in the morning. I called Joe Feldman, who runs a bunch of our urgent cares. I texted him. I said, I just need some help. I don't know how to solve this problem. And I got nonstop back-to-back stuff. So Joe, called her, went over on his lunch break, gave her a flu shot, and said, there's just no chance I was leaving that woman who needed this problem solved for her, without a solution for this. And that's there. That's everywhere. People are authentic and kind, and it is the ray of sunshine that I think carries us through the next couple of days, the next couple of weeks, the next couple of months.
Thanks, Brandon. As we are about to finish up here, I caught in the chat about hugs from small kids, and when I think about these themes that are just so hard, there's a tweet that I saw that just captured my attention, where the mom was listening to her, I don't know what, a young kid doing math on like Zoom with her teacher, and the kid says something to the effect that, today my brain just can't seem to do the math. And the teacher responded on the Zoom, well, then I think you should go out and play, in a most positive sense. And that's probably a lesson we could all learn a little bit from. With that, to the participants, especially the ones that have hung on much longer than we should have gone on, but no, that's not right. We had some really important discussions, and I really wanted to get to a deep dive on these things that we not just bounce off chat and so forth. How do we fight complacency? What do we do with our supervisors that aren't enforcing the complaint? Oh my goodness, goes on. And I couldn't have asked for a better discussion of issues by Laura and Brendan. Really grateful to you, and our panelists always being engaged in helping us move forward. To our participants, so much appreciate your hanging on. Echo, always thank you. You make it run. So with that, I did see in the chat about are the recordings available? I saw that one in there, and all these, every 79 of them are archived on the Echo website, every one of them, with the video and the slides and so forth. Sometimes it takes a little time for the video to pop up, but the slides are there immediately. So, and they're all archived. With that, thanks very much, and take care of yourselves and be kind to each other.